Hello, everyone. First of all, I would like to thank the organizers of this meeting. Despite the pandemic, they were able to gather distinguished speakers. Today, I'm tasked to talk about one of the controversial, hotly contested topics in critical care medicine, and that is targeted temperature management after cardiac arrest. I agree that we need to talk about this again. I'm Dr. Sodusta, and I am an ICU doctor. So this is the outline of my presentation. First, we are going to talk about reperfusion injury, some concepts about reperfusion injury relating to post-cardiac arrest patients. And next, we are going to touch on the history and background of therapeutic hypothermia and briefly talk about the two landmark trials on therapeutic hypothermia. I will try to analyze and interpret the recent TTM trial, the TTM2, which was published just 2 months ago, and hopefully offer some guidance to healthcare providers who treat post-cardiac arrest survivors. So when do people die from cardiac arrest? This is a schematic illustration showing that if you have a patient who suffer cardiac arrest, despite all the initial aspect of resuscitation, majority of these patients will have significant drop in the percent survival. But some patients, however, will do get back, and we call this as return of spontaneous circulation or ROS. This is getting your pulse back. However, most of these patients are in a comatose state. Remember that only 1/5 of patients live in the hospital. There's really tremendous amount of morbidity. And not just morbidity, most patients who survived an arrest will have significant amount of neurologic injury. So just to give you a little background about a concept called reperfusion injury, how does this happen? So when you are in a cardiac arrest, when there is no blood coursing through your body, we call that lack of blood flow as ischemia. So cardiac arrest represents whole body ischemia. Ischemia sets up a number of damaging pathways. Number one is the ischemia forms free radical, also called reactive oxygen species. And this ischemia will enable inflammation to start occurring, causing inside the cell, causing myocardial dysfunction. And third, energy function of different cells in the body will go haywire. Now we know that the lack of blood flow certainly is bad, but the restoration of blood flow, or there's sudden surge of blood after tissue have been restored, is also equally bad. And we call that reperfusion injury. When you reperfused an ischemic tissue, it turns out that all these three things tend to amplify. The reactive oxygen species tends to amplify, inflammation, and of course, energy dysfunction, thus resulting to blood vessel instability. So the blood pressure becomes unstable, forms cell death, and the most dreaded complication of reperfusion injury is brain swelling or brain edema. Again, when blood flow is abruptly stopped and then restored, a number of overlapping mechanisms lead to clinical injury. And to further illustrate, these are the destructive processes following ischemia reperfusion injury that can be prevented or significantly mitigated using therapeutic hypothermia. Now, patients who achieve return of spontaneous circulation, they show significant morbidity and mortality due to a cerebral and a cardiac dysfunction that may lead to a prolonged whole body ischemia. And this syndrome is called PCAS, or post-cardiac arrest syndrome. There are actually 4 key components of PCAS following return of spontaneous circulation. Now, the primary aim or purpose of therapeutic hypothermia is really to lessen mortality and neurologic injury, both. Of course, we wouldn't consider a therapy as a success if we get these patients back alive, but with significant amount of neurologic damage. We would love to have a therapy that both improves survival and neurologic function. When you think about hypothermia, there's been numerous reports about when hypothermia actually started. Aristotle in the 4th century BC said something about hypothermia. The man's superior intelligence depends on the fact that his larger brain is capable of keeping the heart cool enough for optimal mental activity. So Aristotle said then that the heart was the center of the nervous system function. So he already recognized that the importance of temperature control or fever prevention. Even during the French Revolution, there was already evidence for the importance of temperature regulation in shock, trauma, and resuscitation medicine. Wounded French soldiers located farthest from the campsite, they survived the longest. Now, fast forward 100 years later, across the board in animal models of any form of CNS injury or acute brain injury, nothing shows a more important benefit than therapeutic hypothermia. Since the classic publication of Bustos et al. In 1980s, it has been impossible to publish a preclinical study of acute brain injury without monitoring and controlling core body temperature. There's been numerous animal studies over decades of research showing improvement in outcomes with cooling. Strong mechanistic and biologic evidence that if you cool a variety of animal cells after an ischemia and reperfusion, survival is way better. Now forward to 2002, after hundreds of preclinical animal studies that were done, the first two landmark clinical trials that brought hypothermia into our current clinical therapeutic management for post-cardiac arrest survivors were from the IHCA and the Bernard trial. The IHCA trial randomized patients to either no cooling versus a target temperature of 33. They randomized a total of 275 patients. The trial showed a remarkable and statistically significant improvement in survival to hospital discharge when these patients are cooled to 33. A favorable neurologic outcome was way better at 55% with 33 versus 39% with normothermia. And these patients were cooled for 24 hours. The Bernard trial, on the other hand, was published in the same year, had a total of 77 patients. Smaller sample size, though, again showed larger improvement in the survival when patients are cooled to 33. FNO, or the favorable neurologic outcome, was better at 49% of patients who were cooled to 33 versus only 36% for the control arm. Now, since the publication of these two landmark trials, therapeutic hypothermia at that time has been the standard of care for almost 20 years for post-cardiac arrest survivors. However, fast forward to 2013, this TTM paper published in 2013 by Nielsen challenged the benefit and advantage of doing therapeutic hypothermia for post-cardiac arrest survivors by comparing temperature control of 33 versus 36. You know, when this paper came out in 2013, nawindang ang buong critical care community. And because the results were totally different. This study group had a good number of patients reaching almost 1,000. Around 939 patients were randomized. They compare 33 versus 36. But remember, 36 is not normal temperature. There was no difference in outcomes, whether you are going to target 33 or 36. Patient outcomes were essentially the same. Therefore, this was a negative study. So now, how can a world-changing trial like your IHCA and the Bernard, published back in 2002, effectively reversed almost 20 years later? Again, in 2019, the enthusiasm for hypothermia was reinvigorated with the publication of this Hyperion paper published by Lacaro. The title of the paper was Targeted Temperature Management for Cardiac Arrest with Non-Shockable Rhythm. Hyperion studied out-of-hospital cardiac arrest with non-shockable rhythm, comparing 33 versus 37. The total number of patients was really good, around 581. And death at 90 days, although wasn't statistically significant in both groups, however, the FNO was better in the hypothermia group, which was statistically significant. Now, all along, we thought that non-shockable rhythm post-cardiac arrest survivors will not benefit from therapeutic hypothermia, as shown from the previous observational studies. With Hyperion, the results were different. Now, with all the prevailing evidence, TTM being a negative trial, IHCA, Bernard, and Hyperion, positive trials, certainly created again confusions. Confusion, especially when this publication of TTM2 came out. The debate now on the right temperature target for post-cardiac arrest survivors continues. So we are going to talk about in details this TTM2 trial that was published just 2 months ago. So this paper fundamentally tried to address the question, is the value of temperature management after cardiac arrest in the cooling of patient to 33 or just the early treatment of fever at 37.8? The eligibility criteria include adult, comatose, presumed cardiac cause or unknown cause, stable ROSC, no limitation of care, not on ECMO, and not on unwitnessed arrest. After randomization to hypothermia and then to normothermia, which is 37.8, all patients received sedation. They were ventilated and they received fever treatment for at least 72 hours or 3 days. Patient background, majority of the average age was 64. Majority were female, and of course, 70% of patients are shockable rhythm patients, are survivors. And 78 to 80% of patients got bystander CPR, and only 30% were in shock or hemodynamically unstable. 40% of the patients were cardiac patients or patients who had ST elevation MI. Now, with regard to the TTM device, majority of patients receive a TTM device, either hypothermia or normothermia management. And 46% of the fever prevention arm actually used a device, whether surface cooling or intravascular cooling. So there was actually active cooling management going on in the control arm, whether mechanically or medically. With regard to adverse events, there's not much difference in the number of adverse events except for arrhythmia, which was statistically significant for hypothermia. Now, what were the results? The results were neutral. Outcomes at 6 months was the same. So the conclusion was, in out-of-hospital cardiac arrest of presumed cardiac or unknown cause, hypothermia did not lead to a lower outcome, even for all-cause mortality and poor functional outcome at 6 months. So how can this be? 5 different trials, all out of hospital cardiac arrest patients, have such radically different results. Like many trials, the devil is in the details. So we'll talk about in detail TTM2. 90% of patients were witness arrest. 80% got bystander CPR. The median time to ROS was 25 minutes. Then the median time to initiation of BLS was 1 minute. I think the patient included in this trial may have substantially high brain function. So the burden of hypoxic injury is really low, because majority of patients had extraordinary high rate of bystander CPR. With regard to cooling only started at less than 4 hours post-ROS, which can only prevent secondary neurologic injury related to inflammation rather than the acute hypoperfusion ischemia. And the goal temperature was achieved only after 6 hours. And the arrival to goal temperature was 8 to 9 hours. So with that time period, there could have been certain amount of injury going on already within that time frame. And almost 50% of patients in the 37.7 group, or the control arm, receive active cooling device, as mentioned by me earlier. And of those, 2/3 were getting intravascular cooling or catheter. So clearly, patients in the control arm got precision temperature management plus comprehensive post-cardiac arrest care. Now, the time to cooling could be very critical, no? The longer time to cool in TTM2 could likely be the reason for the neutral effects. And this was the same criticism with TTM1. Okay, so the 8-hour delay in cooling negated the effect of therapeutic hypothermia. The population of patients with cardiac arrest could be heterogeneous, and the potential risks and benefits of therapeutic hypothermia may not be the same across subgroups of patients. Obviously, the population represented in TTM1 and TTM2 can't be generalized to the cohort of patients we see here in the country. For one, we hardly or never do CPR outside the hospital. But in TTM1 and TTM2, 80% of patients got bystander CPR. And in our country, we don't have a structured good EMS service. So our traffic situation is so bad that by the time you see this patient in the ER, it's already beyond the optimal window of time to act and time to protect the brain. So cannot be generalizable to our current patients that we see for post-cardiac arrest patients. So this is just the summary of all the 5 RCT trials. Of note here is that TTM1 and TTM2, 70 to 80% of patients had bystander CPR again. Baka patients included in this study weren't that sick, and doing therapeutic hypothermia would not create or additional benefit as compared to both IHCA and the Bernard, where 50% only received bystander CPR. Also, the initiation of cooling was longer with both TTM1 and TTM2. As compared to IHCA and Bernard, which is just around 105 minutes, I think. While Hyperion trial looked at the very sick non-shockable rhythm patients. So it may be very well that, I guess, that you still get benefit of therapeutic hypothermia for the sickest patients. Now, the other thing that is important to think about is the degree of post-arrest injury. Perhaps the disease is not homogeneous as we think, because we know that therapeutic hypothermia or post-cardiac arrest injured patients can either be severely brain injured with severely hemodynamic cardiac instability or with severe post-cardiac arrest syndrome state. Maybe we can break these patients, just my thoughts, into mild, moderate, and severe, or phenotype these patients as to mild, moderate, and severe. For mild patients, these are patients with or had witness arrest with shorter downtime, perhaps no TTM is not needed, or no TTM is needed, actually needed. While for severely neurologically injured, those with prolonged CPR, especially with non-shockable rhythm with associated seizure or diffuse cerebral edema and cardiac involvement, then perhaps we can target 33 for these sickest patients. While for the moderately injured patients, who are in like a single organ involvement or whether just a neuro or just a cardiac involvement, then perhaps why distribute 36 to 37 degrees Celsius. Again, right now, we don't have the tools to differentiate who are the less injured or severely injured survivors, except my opinion, using clinical criteria. Now, it's very difficult to understand how to phenotype these injuries, right? So given that the current trial was neutral, meaning there's no difference in the benefit and harm, and cooling to 33 degrees Celsius is based on extensive lab and animal studies and based on 3 RCTs. And given that we cannot tell who would have significant post-arrest injury based on the current technology and clinical factors, my conclusion, therefore, it is reasonable to not change practice on the TTM, based on TTM, but rather continue to treat comatose post-cardiac arrest patients with the TTM goal of 33, 36, or 37.5, and using a precise method of keeping within that target. And in addition to TTM management in the acute phase, 24 of either 33, 36, or 37, all post-cardiac arrest patients should receive comprehensive best practice post-arrest care, including the avoidance of fever for up to 72 hours following rewarming. So having said all that, completely abandoning TTM is not an option. I would still cool my patients, my post-cardiac arrest patients. Thank you.